So let me try to invite the audience to give us some thoughts on this. How many? We're all, I guess, about the age of parents or beyond. How many of the audience would want to know at the time of the child's birth if the child, a female, had a BRCA1 or 2 mutation? Okay, and how many would not want to know? Okay, so about equally divided. I sense a preponderance of the ayes over the nays, but we'll say about evenly divided.
So the question is, so there's some people who want to know and some people who don't want to know. So the people who don't want to know, should they prevent those who do want to know from being allowed to know? And those who want to know, should they prevent everybody else from not being allowed to say no to the DNA test at birth? I mean, should each, this is a problem that we have at many different levels in society, where there are certain groups in society that are trying to apply their mores to the whole society.
I think that, and yet there are certain sort of social, legal, ethical, and moral standards that society sort of imposes on, or that we say is sort of an overall good, and that whether we agree with the individual choice or not, if we had our druthers, we accept or are imposed upon us. And so it's not simply a free libertarian society for which people can make choices however they see fit. Because also, when you're talking about a child, you're talking about somebody. You're not just talking about the parent making a decision for their own well-being or for their own good. They're making a decision on behalf of somebody else, and I think that's a little different.
Well, but that somebody else is their child. And as I said earlier, we give parents a lot of leeway to make decisions for their children up until the legal age of adulthood. And that's the way this society works. Other countries are not so much like that. The government does decide. I'm very worried about, if you talk about a particular treatment or a particular test, there are two kinds of goods. There's good for the health of the child or good for the health of the society versus a kind of a social mores that you're trying to protect. And this is a very pluralistic society that we live in with lots of different points of view. And I would worry very much that a group with a particular kind of social mores would try to impose that on others who didn't have it.
Is there any reason not to configure this as an opt-out system? That along with the standard Guthrie card for PKU, every parent is offered the opportunity to have a panel of 25 genes sequenced for cancer risk. And if you don't want to have it, you have to opt out by signing a card. Is there a legal or a constitutional problem with doing this? Is there a moral problem with doing this?
I don't know if it's legal or constitutional, but I think that the standard of care generally today, the ethical standard of care, is that we generally don't do gene testing of children for diseases for which there's no treatment option. And there may be, in fact, and by the show of the hands, there's a group of people that sort of disagree with that. But that doesn't necessarily mean that that's a good, that that's sort of generally a good, sort of a social good. I think that I think that when you're talking about a child and somebody else who ultimately and this information following somebody sort of along through their life and having a huge impact both in the sort of the child rearing and otherwise, I think we ought to really take some pause in terms of whether we want to know whether somebody has a predisposition for which there is no treatment. I'd be curious to know why parents would want to know that.
Well, I think just one thing with BRCA1, I mean, there's a concept that there is a treatment. I mean, it's a severe treatment, but, right, and when the woman goes through puberty.
So good. I see some hands in the audience, which is, so Dr. Rapson was first.
I guess the question would be, and there's a science piece of this also, is there may be a prevention, and can we ever know? I'm not even talking about the surgery for BRCA1, but for example, if I had a daughter with a BRCA1, I would not have barbecue during menarche, during pubertal development of the breast. That child would likely be encouraged to be a vegetarian during that.
There you go.
We don't know that prospectively. We'll never even be able to do science past the question of whether it makes a difference. So at some level, there could be a greater value to at least certain people knowing that, and either on an individual basis or from the standpoint of a knowledge basis, being able to then ask questions about prevention that would involve lifestyle, etc.
Dr. Todd, you had your hand? Made the same point. Dr. August? Get the mic, please.
To explore the logic of this, let me just ask this as a question. So if we offer parents the opportunity to opt in or out for their children, doesn't that logically obligate us to allow adults to opt in and out for themselves, so that anybody who comes to us, to the healthcare system, and says, I want my genetic profile, if we're going to do that allow parents to make that decision about their newborns, shouldn't they be able to make it about themselves? And then in a little bit different context, patients come into my office all the time saying, I want a CAT scan, I want my third colonoscopy in 2 years, and we just draw the line and say, look, that's not medically appropriate, and I'm not going to order that, and I'm not going to suggest you go to anybody else to get that ordered. So isn't there some fundamental illogic in this opt-in, opt-out, that anybody ought to be able to decide what they want tested for?
It's an economic question, okay? Somebody wants a CAT scan. If you open up a CAT scan, clinic on Route 1 and charge people $100,000 for a CAT scan, I have no problem with that. If I want to pay to see my genetic profile, I think I should have every right to pay somebody, just like Jim Watson. He didn't pay anybody, but Jim Watson just had his DNA sequenced, and it's up on the web, I guess, right now, right? I don't see how you would think that it makes any logic whatsoever to stop somebody from gaining information about themselves, except economically. You obviously don't think insurance should cover this. I don't think so either, or the government should cover this. I agree. But I distinguish those two.
I saw Dr. Totmeyer. Just wait 1 second for the mic, please, Deb.
I tend to think it's a little bit more than an economic issue. I think that many times, to just even go back to testing a child or a newborn, a lot of this is to alleviate the parent's anxiety. And quite frankly, although Arnold, that may be you saying that your daughter should have a vegetarian diet. She may want to eat burgers and French fries, and for any different way. And I think unless there is something, you have to ask yourself the question of why are you doing it. In the same way with CAT scans, you can have an anaphylactic reaction. You can find a Ditzel that leads to a biopsy that leads to something else, and it's more than economic considerations. And I think that there are anxiety, emotional issues. There's a whole component about this in terms of what is going to be the repercussions on that child living with that information that we have no idea about at this point. So although, the technology is there, the question is how best to use it. I don't think should not be indiscriminate.
Well, the question is, who makes the choice? That's really what it comes down to. You can provide all the information you want to these parents, and then in the end, who has the choice? The physician makes the choice, or do the parents say, I know you don't like me doing this, but I want to use my own money to do this? Would you say no to the parents? Okay, well, I disagree. So.
But I think physicians, in a sense, physicians are making choices or are sort of making professional judgments along the way in a lot of different instances. And so when somebody goes in and has indications for things, there's a tremendous reliance on sort of that that physician-patient relationship. And I also think that it's a bit of a misnomer or sort of a falsehood to assume, I mean, taking this panel up here, that everybody going in and getting this information graduated either from Penn, Yale, or Harvard, and has both the intellectual context and ability to absorb that kind of material and contextualize that kind of material in a way that they can make good choices. Now, the question is that paternalistic? Maybe. Doctors tend to be a paternalistic profession in a lot of different ways. But I think that we need to sort of recognize that we're not always talking about an Ivy League educated consumer who's listening and understanding this information, and who's going back to their home in Princeton and deciding, well, gee whiz, here's what we're going to do, and here's how we're going to react. I think there's a wide range of folk.
Yeah, but I think that in the end, it's a question of, I can tell people 30 years old, don't smoke cigarettes.
Right.
400,000 people a year are killed by smoking cigarettes. That's clear. So would you make cigarette smoking for 30-year-olds illegal? I mean, that's really what it comes down to. You would.
I think cigarette smoking, tobacco smoking is a tremendous public health hazard. And the reason why it's not illegal is for all sorts of political and
people are addicted.
and historical reasons and so on. And if we were redoing it, there's very little reason why we would sort of allow tobacco smoking and criminalize and throw people away in jail for smoking a joint.
We have a comment in the audience. Yes, sir.
So for the case of a late onset disease, so you don't screen for 10 years, all right? And after 10 years, there's a prophylaxis or treatment that's discovered. So now you have 5 to 10 years of children who were born who will probably never go in for the genetic testing. That could have been, their physicians could have flagged them. Is it ethical to do that?
So you're speaking to children who get...
The question was, do we screen babies or not? Okay?
Right.
So if you don't screen for something that's a late onset disease, and then 5, 10 years down the road, basically there's a prophylactic or a treatment that's discovered. So now you have 5 or 10 years worth of births that have never been screened, and probably will never go in for genetic testing. Is it ethical for us to do it do it that way?
And that's what your scenario is extremely likely. I mean, if you screen the entire genome, there are conditions right now that we would all consider to be diseases that have no treatment at the moment, and some of them are going to have treatments 10 years from now.
Or treatments within our lifetime, certainly. I mean, or within our children's lifetime, the treatment. I mean, it kind of begs the question of whether people are going to be able to afford these treatments, and sort of the coming back to the issue of equity, and cost and so on. But science is a moving target. I guess to go back to our earlier speaker, a very compelling talk about vaccines. Is genetic testing for adult onset predisposition diseases where there may be a risk of 12%, is that, if you have the gene, is that similar to where we are as a public health matter and a matter of public policy with respect to mandatory vaccinations?
Where we now with HPV are vaccinating children because that's the most efficient time to vaccinate them before they become sexually active. And we are preventing an adult disease by an action taken at 9 years of age. That's the
well, there's a
analogy.
treatment plan. I mean, there's a...
Well, it prevents the disease, but
Right.
it's preventing an adult disease.
But it's more than that, because it's not just benefiting the individual, it's benefiting the population. So if you look
in
at...
vaccination.
Yes, vaccination benefits the population
no,
as
I
a
agree.
whole.
So
Genetic testing may be different.
Yes.
I'm reminded of discussions that occurred in the 80s with another completely non-controversial topic, and that is infection with human immunodeficiency virus. And I'm reminded of the situation in New York City, for example, where umbilical cord blood was collected from women giving birth and analyzed for the presence or absence of HIV infection, but the blood was anonymized. And so the women couldn't be told whether they had HIV infection. And this was done for a variety of political reasons that everyone in the audience knows or can imagine. But this practice of anonymizing blood continued well into the era when pediatricians could prevent serious consequences of HIV infection, even if the babies already had them, by treating with prophylactic drugs for fungal disease and by treating with azothymidine. And it became clear after a number of years that this was unethical, and that the practice of not telling the mothers that they had HIV and had a 30 or 40% chance of transmitting it in the service of some political agenda was unethical. And I wonder if there's not an analogy to be drawn between simply not drawing blood and doing tests that we can do now because we're afraid of the effect that it might have on the psychological development of the child or the privacy rights of the child. I wonder if in 10 years we're going to look back and feel we did something wrong.
But don't you think...
We'll get to you in a minute.
Sorry.
Mary, why don't you...
We will, but right now, the only thing that we know that works is what we heard today is oophorectomy. And I don't think anyone's going to do an oophorectomy on a young child. And so what is the point of learning that when you're not going to have something you can do?
And I think, I mean, I think your example sort of points to that as we have experience with science and with a rapidly developing revolution in science and medical technology and so on, ethics is also not set in stone. And ethics in some way sort of societal values sort of change or become more comfortable. Not that ethics is always contextual, but there's a sense that as we learn more, as more information is put onto the table about sort of various different treatments, that it may be that standards of care change in such a way that what was once a standard of care in 10 years may be a different standard of care. It begs the question that you asked about sort of what do you do for the cohort of 10 years of kids that are born, you know, I mean, you can sort of draw the line from, you know, the moment in 1999 when I'll just say Clinton and Collins and Tony Blair across the pond sort of announced in the White House that we've now gotten the draft of the human genome. At that point, we didn't start testing everybody, and so we've lost that cohort too. And so it's always an evolving thing, and it becomes, and the question I think is, at what point do you stick your toe in the water and say, okay, it's time to start now?
Professor Hill?
Yes, I just want to say, going back to something that Lee said earlier, that the question is who makes the decision. And it seems to me that the prior question is what is the decision? And if in fact you prevent parents from knowing certain genetic information, or if you refuse to take steps to address the possibility of some sort of late onset disease, then you do make a decision. But the decision that is made is a non-decision. And it's made in the absence of information on the part of the parent. And it seems to me that in that sense, then, the decision is one that is highly uninformed. It's made in the absence of information. It's almost, in moral terms, it's almost an abandonment of one's responsibility. And this is being aided and abetted by the medical profession. This I find unconscionable. I think that we cannot run away from the fact, the moral weight of information and knowledge that we have. We can't bury our heads in the sand and pretend that we don't know what in fact we do know. And so the question then is, what is it that we know? And on the basis of that, what is the decision that ought to be made? Then you can say who ought to make that decision.
Well, I think the first thing, of course, is that a decision to do nothing is a decision to do. If you do nothing, that's still a decision that you're making. Information changes over time, so we learn more over time. We may have more information. But at any moment in time, you do the best that you can to do utilitarian calculus, looking at the risks, speculative or not, and you're looking at the benefits, whether they're long-term or short-term. And based on that information, I mean, if you have an informed consumer of that information, I think the consumer is best placed to make that decision, because the risks and benefits might be different to that person than to the doctor. So I don't see how you can take that decision-making power away from the individual, unless the population as a whole really might be affected. So, for example, in the case of vaccines, that is a clear example where you have to protect the population by vaccinating all children. But in most of these cases, we're talking about individuals here.
Dr. August?
As you make that utilitarian calculus, though, I think we're ignoring a very important set of issues here, that in a very practical sense, to think about obtaining all of this blood, purifying the DNA, banking it, keeping track of who these people are, where they are, the whole concept of saying 10 years later we now have some new test, and then going back and retesting everything, all of the genetic counseling that needs to go on to make this kind of system, I think, both ethical and practical. In a very real sense, I think that, in the end, dictates much of the utilitarian calculation here, that it just becomes totally impractical.
If I can just interject, we without taking one side or the other, we do have such a system already in the United States, and actually in most of the developed world, as I mentioned, for collecting protein blood samples on newborns. And it would be possible now to begin the process of identifying specific high-risk genetic targets, not to sequence the whole genome, but to identify specific genetic changes with known risk, with the potential for intervention at some time before the cancer develops, in the same way that we identify phenylalanine levels or methionine levels or branched chain amino acids in these samples. And there's already an architecture and a structure for notification, for genetic counseling of these parents, et cetera.
But I guess I would argue that once you begin to defer those interventions, that the cost of that system in a very practical way becomes astronomical. Mm-hmm. It's one thing to say, we've identified a PKU child and we need to undertake that intervention right now, and this is a 1 in, 20,000 kind of thing, as opposed to now we have a cohort of hundreds of thousands that we need to keep track of over the next 40 years as medical science develops, so that as interventions come online, we can then contact them and counsel them and offer them the appropriate intervention.
In fact, the more efficient way, if we're talking about efficiency and utilitarianism, is to basically, since the genome doesn't change, and there's going to be, and assuming, for the sake of the discussion, that there's going to come a moment in time where there is an intervention available, then presumably at that moment in time, there'll be a press conference, I'm sure. It'll be somebody from NIH who will love, yet again, more press conferences. And we'll talk about it in Time Magazine or the blogs or wherever. And people then can make a decision. And I'm sure, quite frankly, the drug companies will be very happy to have marketing and TV ads and commercials and so on to basically say, we've now got this cure or this intervention for this kind of cancer. while you're going to get your Zoloft and going to get your other things, go and get a gene screen, figure out if you're at risk, and we'll intervene at that point. And I think that way, going back to the question of information that's before, somebody can make an informed decision about what that intervention is and choose either to go forward and be tested or not, rather than waiting for government to call.
Dr. Haidt?
So just a comment perhaps, and maybe a question. We may be mixing apples and oranges for the moment, maybe not. At birth, the things that we've screened for the most part, have told us that the newborn has a disease, and maybe there's an intervention as well. The other topic is screening for a susceptibility, where there is no disease, and only a small percentage of the population will ever get that disease. That, I think, makes the calculation more complex, if I'm not mistaken.
Yes. Some of the tests for which screening is done have a wide variation in the normal phenotype. And so frequently retesting is necessary to ascertain whether or not the disease is present. But you're quite right that that testing is done at that time, and treatment is, or at least watchful waiting is initiated at that time. The case of BRCA1 is clearly different in the duration and in the probability. Even more so with SNP.
But I think, I mean, it's again a question of calculating cost benefits. I mean, a PKU test costs, I don't know, almost nothing probably. At the moment, most of these genetic tests are more expensive, and so if the probability of benefit is very low, then you have a higher cost, lower benefit. You decide that you're not going to use public funds to do that.
But there is no, but the fact of being, or I would submit that the fact of being tested for an adult onset disease where there's a probability, a risk probability of that disease, is not a zero cost proposition.
No.
There are costs involved. They may not be financial, but they're sort of social, personal, psychological, and sort of other kinds of costs that I think we need to keep in mind in making that balance.
And I would agree with that, and I would say the best person to decide what the personal costs are the person.
And that society can't make, that either society or the medical community, the medical profession, cannot make a judgment about or say anything about those costs, those non-economic costs, that it's really to the that it's a strictly libertarian up to the individual?
No. I believe in the maximal amount of information being provided, but the information may say, in general, 70% has severe depression if they discover they have an AGT, but 30% don't. But then I would argue the individual, people are, some people make really stupid decisions, and other people who you think are not well educated actually understand things and can make good decisions. And I don't see how any authority can talk to an individual who's judged competent and say, I know better, I'm telling you what to do here, as opposed to the individual having the information and making that decision. It's a very different political point of view. I mean, it's more of a libertarian versus a paternalistic point of view.
Gunther?
Just based on what we're talking about here, I see a real issue where you could have, let's say this BRCA gene is now included on a prenatal screen, and then the decision can be made whether or not to have that baby. And I think that's something that I think is both realistic and a concern, and we need to talk about the ethics of that as well as the things that have been mentioned already.
Well, I believe, you can correct me if I'm wrong, in this country, during the first and second trimesters at the moment, a woman can have an abortion for any or no reason, period. So, I mean, you can talk about whether you think it's ethical or not, but it's certainly legal at this point in time for a woman to have an abortion in this country. And you can try to convince a woman not to, but in the end, it's her choice.
Another way of sort of looking at that is a woman has the right to have an abortion for no reason, and a woman similarly has a right to have an abortion for a bad reason or for the wrong reason, so to speak. And so, and I think in a sense, the libertarian in me would say that's right, that basically making choices, individual choices about from the parent's point of view or from the woman's point of view is basically where I want to place that decision. I guess I would differ, and maybe the people who are putting on the conference don't want to go there, but I would differ that when you're talking about the future life of a child who will be born and live with that decision, live with that information, that there's a different calculus there.
I agree with you completely.
That'll get you some more funding.
In the back row, sir?
This entire discussion has taken place in the context of a medical professional and an individual, which is certainly extremely important. But there are at least two other spheres where genetic information has enormous implications, insurance and employment. And I was hoping Paul might say a few words about those issues as well.
Well, I would say that the risk of discrimination, both in the context of insurance and employment, are very real with respect to identifying sort of predisposition information. And we've seen some evidence of that, but not quite frankly, not a whole lot of evidence. And I and others have tried to sort of figure out why that might be, or whether we're just at the beginning of a wave that the costs are not quite there yet, that employers are going to be using that information, or it's not that readily available. But the great fear is that, in a sense, that to the extent, regardless, again, of the decision that the parent makes on behalf of his or her child, that decision ultimately will follow that child through his or her life, regardless of whatever privacy constraints you put on, because I think that there are, in today's society, there are very few things that ultimately will remain private, and therefore, to the extent that an employer somewhere down the line learns of somebody's predisposition for sort of a cancer at some adult onset point and doesn't want their health insurance costs to go up as an employer, or doesn't want to invest in a particularly promising young PhD candidate coming out of her postdoc, because ultimately they might get breast cancer by the time they're sort of reaching the stage of real great productivity, so better not worry about that now and move on to the next person. Or in the insurance industry, where you're creating a category of people where we have a private insurance system where not everybody's covered, of a large group of people who are simply never going to be covered because of their genetic predisposition. I think that's a real problem, and I would be very concerned. In fact, I know that many genetic counselors are in their conversations with their patients are feeling it necessary and appropriate to talk about sort of what are the ramifications of having a genetic test, irrespective of sort of how they do it in the privacy concern.
I think it depends on what the purpose of insurance is. I think that a good society has an obligation to provide basic health care to all of its citizens, irrespective of whatever genes or anything else that they carry. So then genetics should have nothing to do with basic health coverage. But there's another kind of insurance where discrimination is carried out right here in New Jersey. And if you have this gene, particular gene called SRY, it's an auto insurance genetic discrimination. You pay several $100s more in insurance, pure genetic discrimination. as probably most in the audience know, this is a gene on the Y chromosome. And if you have a child between the ages of 18 and 24, and it's male, maybe the safest guy in the world, but he's discriminated against because he's got this gene, and the girl might be really wild, and she pays less money in insurance. So it's pure discrimination, not based on their actual account of how they drive. We accept that because auto insurance is not a right; it's a privilege.
Did I see another question, comment?
Insurance companies already do this, and legally so. I mean, they refuse to hire people who are smokers or of other risk factors due to obesity and so on. They do so legally. So it's already happening.
They do, well, yeah, I mean, they underwrite in insurance and so on. But to the extent that the things that they're underwriting, smoking, for example, one could argue, we talk about the addiction of tobacco, but here you're talking about somebody's sort of genetic characteristic, which they can do nothing to change, and may in fact sort of create only a 12, 15% risk of something of the condition happening. And whether we as a society want to sort of lay out insurance in that kind of way, I think is a question that, as this federal legislation that's being discussed as we speak now, that's really sort of up for grabs. That's really a very healthy part. I mean, we haven't done genetic testing of the general population heretofore, and from what I understand, insurance companies are doing pretty well in terms of not having that information and not having that information to exclude people from health insurance. I think that issues like, I think there's a distinction between the way that we've set up the system between health insurance and access to health care and auto insurance, or even, for that matter, the argument could be made for life insurance, which is more of a financial product as opposed to health insurance. So I think that there are distinctions there.
I agree.
So let me just ask one more question, and then maybe we should begin to wrap it up. Do you think it would be moral or legal for the doctor who's coming to see me in a couple of weeks, well, the doctor who's coming to see my daughter in a couple of weeks for an insurance physical, a life insurance physical, to request a sample of blood for the purpose of sequencing BRCA1 and 2 to determine her risk of breast cancer? She's going to be tested for all kinds of illicit drugs. She's going to be tested for cogentin. She's going to be tested for the pH of her urine. I mean, all of these things are going to be tested. Why not test her for a potential genetic defect?
I think that because the question of the relationship between the presence of that gene and the disease is different. It would be one issue.
I would say that yes, they should be able to test, and it's because we clearly don't have a perfect society, but in a perfect society where you had a basic social safety net that everybody was covered by, then life insurance would be kind of on top of that. And life insurance companies, their purpose is to make money. And if you have 1,000 women with the BRCA1 mutation, they know that 70% are going to get the cancer. It doesn't matter which ones get the cancer. So probability really helps insurance companies.
And would you create any distinction between types of sort of conditions that an insurance company, either health or life or what have you, should be able to test for? Or because they're not going to test for, because here's the other sort of wrinkle, and I won't even define it as a problem, but it's a wrinkle. And in terms of people can't test for 10,000 different conditions. And basically say we're not going to cover anybody that has any kind of genetic mutation. There'd be nobody to insure. Everybody's got something. So they're making a choice, a policy choice, in terms of saying we're not going to cover these conditions, but we are going to cover those conditions. And so the question is, ultimately, how do you make those decisions? How do you again draw the line against the panoply of conditions that maybe not today, but in 10 years or so, that we'll be able to easily test?
Well, life insurance companies...
Just one other thing, keeping in mind the discussion that we had a little earlier about cystic fibrosis and sickle cell, that there are sort of cultural and historical factors that undergird some of this sort of decision-making about health and disorder.
So I would separate, as I said, health care from life insurance. Life insurance companies, their purpose is to make money. And 30 years from now, they'll ask for a total DNA profile, and every single person will get a score, and that's how they're going to charge, And if it's a market for insurance, then they're not going to be able to charge more because somebody else will give you a cheaper policy.
I saw a comment or hand before in the back. Yes, sir.
Last comment was the question of whether we should be sequencing BRCA. And this is we lump two things together. It's one thing when you test someone for the 5 known Ashkenazi mutations which clearly have clinical significance. But one of the problems with sequencing genes like BRCA is we don't know what many SNPs mean. I'm speaking now from someone who sent off sequencing, and you get back, well, this patient has SNPs, we don't know the clinical significance. And so it's one thing to tell someone their baby does have the gene or does not. But you've kind of skirted the issue of, well, your baby has a SNP, we don't know what the significance of it is. And that's the worst possible scenario, and it's one that is incredibly common.
Thank you.
So I think it's very important to go back and watch the movie Gattaca, because there's an in-joke in that movie. There's a point in the movie where the star, Uma Thurman, what's her name? Thurman, right? She goes and she's getting the sequence of her boyfriend. And she gets the sequence, and she opens up the paper, and it's a whole long series of A, G, C, T, D, G, and that's what she's looking at. Of course, that's meaningless, right? I mean, most of the genetic information, we have no idea what it means. It means, so why not give it to the parents? It's meaningless. But I mean, someday it won't be meaningless. And someday when you correlate particular haplotypes with particular probabilities of disease, it won't be meaningless then.
Okay.
But what its meaning will be is still
probabilistic.
Is that you?
To see.
Is that you, Dr. Rubin?
Yeah. So, Dr. Silver, since you brought up Gattaca, I think it's very interesting. So the idea, though, of having genetic information that might go to the insurance company, which again, they can. It's a private company; they can do as they would see fit. But that information then becomes prognostic for all kinds of things, including job potential in Gattaca. And so I guess the idea would be, is that opening a Pandora's box where that information then becomes sold to various groups because they want that information?
It's a private company, but it's also regulated. And so I was thinking about that. To the extent, would we feel comfortable with a life insurance company saying, well, you know what, we just think that the likelihood of death of an African-American male is higher than the likelihood of an early death of a Caucasian male. Therefore, simply on the basis of race, we are going to price life insurance products very differently. Problem?
Yeah. It's not, well, we don't have to go into that now.
So with that unanswerable question, I think it's time to bring our conversation in on time and under budget. I want to thank the audience for participating. It was my hope that you would join us in this conversation, and you did. Ned, do you want to make a few closing comments? So we want to thank the organizers and the Institute, this Institute, for hosting the Cancer Institute's Governors Conference. And I hope to see you all soon. Thank you very much.
That was great.
Debate.
That was really fun.
Yes, I enjoyed
I didn't
it. Very
expect
much.
it to be a debate.